All right, welcome everybody. This is the third PT talk of the year. Today we're shifting focus a little bit away from kind of physical body part talks to pain science and balance. So, there are certainly some anatomy components to this, but it's going to be talking more about kind of perception and how we process different signals that come into our body. Okay, so we'll cover pain first. We're going to talk a little bit about how we detect pain, how we sense different sensations, and then things that can happen when we have pain and changes that can happen over time. So we'll kind of go through all the components of that pain sensory system, including the anatomy, what are the different receptors, the nerves, the spinal cord, and stuff like that. And then we'll talk about how our body can become sensitized to sensory input, which can lead to chronic pain or more long-lasting pain. And then we'll talk about how, as PTs, we kind of approach pain with different treatments and different ways to modify how we interpret that pain. And then we'll shift into balance, and we'll talk about different components of the balance system. So our vision, our proprioception, and then our vestibular system. Okay, and then we'll talk about those, and then we'll kind of talk about some kind of common balance disorders, and then we'll talk about ways you can work on your balance at home as long as it's safe. Okay. So getting into the pain system here, these are really the different types of, or this is the anatomy of the different components. So the first is the sensory receptors. I put in nociceptors here. Those are typically the ones that detect pain, or they're most associated with pain. But these are different nerve endings and sensory receptors that are located throughout the body, really in almost all tissues. And what they do is, there are the little sensors out there. They detect some type of sensation. So different sensors detect different things like temperature, pressure, touch, and then they relay that up through the nerves into the brain. Okay, I have a diagram. The skin has almost all of these in, because the skin is our first interaction with the world outside of our body. So we want to be able to detect all different things. So the skin's a great example of highlighting all these different types of sensory receptors. Then the nerves. The nerves are what connect the sensory receptors all the way up to the brain, or to the spinal cord. And then at the spinal cord, that signal is relayed. It can take different tracks through the spinal cord based on what is detected, kind of on the skin. And then those signals are sent up to the brain for processing and interpretation. Okay, a couple other things that work in the system: neurotransmitters. These are the little chemicals. Each time a nerve reacts or interacts with another nerve, neurotransmitters are what allow that communication to take place. And then reflexes. Reflexes really are a sensory function. And so if you've ever been to the doctor and they take the little reflex hammer and hit your knee, this is testing your sensory and your nervous system. And so what these are protective mechanisms dealing with sensors in our side of our tendons. And so this is one way that we test this system. Okay. All right. So here we go. This is a schematic of the skin. So here's the top of the skin, your hair follicles. And so within the first few layers of your skin, we have all these different types of sensory receptors. Okay, and I have a diagram a little bit in a couple slides that goes through what each one of these different sensors detect. And so you can see, like down here, this is the root of your hair. So when you kind of feel a breeze that goes across your hair, these are the sensory receptors that detect that, and then they send that signal on to your brain. Okay. Here's kind of a similar example of the skin, or the different sensory receptors. And then here, this is a muscle fiber, or a muscle. And then here's a tendon down here. So when we're testing our reflexes, we're testing this thing called the Golgi tendon organ. Okay, so if a tendon stretches too much too quickly, it kicks on our muscle to help prevent that stretch from damaging the muscle or the tendon. And then the other thing that we'll talk about a little bit later on with balance is this thing in here. It's called a muscle spindle. And what that does is it detects how much our muscles are stretched, give us an idea about proprioception, or where our body parts are in space. So if you're holding your arm overhead, we're able to detect that and know that without seeing it with our eyes. These are the types of sensors that allow us to do that. Okay. So one thing I wanted to point out, we have all these different receptors in our skin, in our bones, joints, and all the different tissues. Well, they do travel at different velocities going into our brain. And so if you look up here on the top, these are our fastest ones. So that muscle spindle and that Golgi tendon organ that I just talked about, those are the fastest ones. These are typically our reflexes, where sometimes that signal doesn't even go all the way to the brain. It's just an automatic, like if you're about to touch a hot stove or you're touching a hot stove, that signal doesn't have to go to the brain. You're kind of pre-programmed to get your hand out of danger. And so, that's why we want a really fast signal transmission there. Then when we start getting into other senses, we talk about A beta, A delta, and C fibers. The A delta and the C fibers, these are the ones where we typically detect pain, so noxious stimulus. And these are the ones we're going to talk about mostly with pain. Most of the other sensory receptors detect touch, pressure, vibration. There is some position sensation, and then the stretch of the muscle. And so this allows us to use different modalities and techniques to kind of overwrite this noxious stimulus, this pain stimulus. And so, if you ever use TENS or heat, or if you ever kind of bumped yourself and kind of rubbed it, this is kind of what we're doing. We're using these other sensory inputs to kind of overprint that more painful or noxious stimulus, and that kind of helps us feel a little bit better. It takes that signal of danger down a little bit. And so this is kind of the basis of what we use for some of our PT interventions. We'll talk about those a little bit later on. Okay, so we talked about a lot about sensory receptors. So those pretty much all lie in the tissues outside of the brain. And then what happens is, here's your sensory receptor, and then it sends a signal down this neuron, or the nerve, that goes all the way to the spinal cord. When it gets to the spinal cord, it has to relay that signal into a different nerve that runs up the spinal cord and into the brain. Okay, this is where neurotransmitters become very important. So one of the ways we become hypersensitive to pain is when those neurotransmitters and the little receptors on the different sides of the nerves become more present. So our body can put more sensors there if they're getting more of a signal. So if there's more need, our body puts more signal there, or more receptors there, so that when we do detect something out on the skin and that signal comes in, there's more sensors to relay that signal on. And this is sometimes why pain becomes more intense over time, is because our body's kind of over interpreting, or that signal is being relayed, but it's a little bit stronger than it would have been under normal conditions. Okay, so one good example of this whole system is, if you're driving your car and you get a low pressure light, the signal that comes on in your car is kind of what your brain is interpreting, but really the signal is starting out at the tire and it's telling you, something's not right. Like the air pressure is too low. And so it sends that signal on so that we can do something about it. Okay, so that's a good example. It's kind of a parallel system that everybody can sort of relate to. Okay, so we talked about nerves. I just wanted to leave this in here. This is something we've used in previous talks, but these are all the nerves that kind of go throughout the whole body. And you can see they all come up, interact with the spinal cord, and then all those signals get relayed from the spinal cord up into the brain. The brain is where we start interpreting those signals. So if you've ever had anybody tell you that pain is in your brain, it's sort of true. It's kind of where we're interpreting the signals that our body is sending, so that we know if there's danger or if we're sensing something else. That's when we start interpreting it. So let's talk a little bit about what pain actually is. So I grabbed the definition out of just Merriam-Webster, and I'll kind of sum it up without just reading through it, but it's an unpleasant bodily sensation or a combination of sensations that our brain interprets as a noxious stimulus, and so it detects pain. It's usually associated with some type of pain or disease or an acute injury, um, and then it's kind of a warning sign of tissue damage. So our brain can detect that something's going on with our body that isn't right, and so we can change what we're doing, move our hand, move our foot if we're stepping on something sharp, or something like that. And so generally pain is just a sensory reception that is not pleasant, potentially indicating bodily injury or something like that. Okay, acute pain, this is kind of more of a short-lived thing. It typically occurs with an injury or an illness, and it can vary in intensity based on how big the injury is or how severe the sickness or illness is. This also has to do with a person's own perception of pain. So some people say they have a really high pain tolerance, some people have a really low pain tolerance, and so if it's the same injury with two different people, it may not feel exactly the same. And this is why as PTs or most medical professionals, we always ask you to describe the pain. What are its characteristics? Is it sharp, shooting, dull, achy, burning? And those all kind of tell us different things about what could be contributing to the pain. Okay? Now, when we get into chronic pain, this is a little bit different. Historically, we've always considered chronic pain lasting 3 or 6 months, something more long term. But really, that perception of what chronic pain is has changed more recently. And now we kind of look at it as pain that's not necessarily described by an underlying presence of like injury or illness or like muscle malfunction or anything like that. It's more the pain we can't describe. And so this is when we start having to look holistically at the whole body, because this becomes more of an emotional and psychological um, regulated thing as well. And so it gets more complex when you get into chronic pain. And like I said, it's not necessarily the length of time, but it's kind of the mechanism for which the pain or where that pain is coming from that we look at now to describe chronic pain. Okay, one thing I wanted to talk about is pain sensitization. So I talked a little bit about this before. When our nerves start to upregulate or increase the number of receptors where those signals are transmitted across. And we know when we're initially injured, our body becomes a little bit more sensitive to that signal. So we're more aware of it. So if you've burned your hand once, you kind of know your body's ready to detect that again. So the next time you pick it up a little bit quicker. It's kind of, we're a little bit more hypersensitive to it. Okay, so as you can see on the chart here, this is on the bottom, this is the intensity of the stimulus and or painful event or anything like that. And this is the intensity of the pain that you experience. So you can see this is a normal response, the solid line. Okay, so this is maybe before you've ever had any injury, everything feels good. And say, you're in this area right in here, you get some kind of stimulus, some kind of injury, and then as you become more sensitive, you can see that it takes much less stimulus or a lower intensity stimulus to cause the same amount of pain. And this is called sensitization. Okay, this can happen both at the sensory receptors, which is called peripheral sensitization, or it can happen at the spinal cord, where those nerves transmit the signal into the spinal cord to send it up to the brain. And that's called central sensitization. So you don't really need to remember all of that. It's just I wanted to point out that our system becomes more sensitive when it's exposed to a painful event. Our body kind of remembers that. And so the next time it may be more painful, or it may be painful at a less intense injury or stimulus like that. Okay, here's kind of a similar graph. Down here is kind of the normal response we would expect to feel with some type of painful stimulus, like a bee sting, for example. And then when you have some type of nerve damage or sensitization, you can see that the pain gets worse for the same level of injury or insult to our system. Okay, another concept here that this graph represents well is this thing called allodynia. And so allodynia is when you start feeling pain, but it's would be a stimulus that wouldn't typically cause pain normally. So an example of this would be, if you brush your hand across the hair on the back of your arm, we can detect that, and it's not painful. We know that that's not a harmful type of event. It's a way to sense, or the wind's blowing across that. Now, if we're really sensitive over that area, like if you had a burn or something like that, it may become so sensitive to the point that it starts being interpreted as pain. And so that would kind of shift us down into this area. That's called allodynia. And so something that wouldn't normally be painful, causing pain, that's what we're talking about. Okay, another form of sensitization. Okay, so when you do have pain, there are some things we know that can make the pain worse. One of those things is kind of ruminating or just focusing on it all the time. Our brain, if we're putting all of our kind of emotional and intellectual thought into it, can kind of make that pain grow and worsen. You may actually experience that pain spreading a little bit in the area where the original pain started, and it may even spread to the other side or to the opposite side. So if I, for instance, have pain in my right arm, I may start feeling pain in a similar spot on my left arm if we focus on it too much. This is kind of the same thing as pain catastrophizing or pain catastrophization, where we're focusing on it, and psychologically we're starting to make that pain worse in our head, where we're kind of amplifying how bad that we think the pain is. And so we get kind of stressed out about it, and it's kind of the snowball effect where pain gets worse, we get more stressed, the pain keeps increasing, and it's kind of this runaway effect. And this is why we like to try to get pain under control as quickly as we can. Okay, and we know the longer that the pain lasts, it can, like I said before, it can actually start to spread. You might start feeling it in the opposite side. It may spread to a greater area. If it's in your arm or your leg, you may start feeling a greater area that starts to hurt more. Also, if we don't understand the pain or understand what's causing it, we may continue to do activities that make the pain worse, or we're not doing the things that we need to do to treat it. And so understanding it is a good thing. Psychologically, feeling helpless about the pain has shown to make that pain worse over time. And this has a lot to do kind of with psychological stress as well as hormones. And so, there's some things we can do to help treat that. Fear avoidance. So sometimes people are a little afraid of doing something that may hurt a little bit more, but in the long run, it's actually going to make the pain feel better. This is what we call fear avoidance, where nothing's really going to change that because it hurts. That initially it hurts to kind of treat it, but that's really what needs to happen to make things feel better. Anxiety and depression. We kind of talked about those a little bit with emotional stress, but being very anxious or having that feeling where you just can't ever get ahead of it, that depression, we know that those things can contribute to making that pain worse over time. And then, surprisingly, as we age, we tend to actually deal with pain a little bit better. So the younger you are, you may experience greater levels of pain, but we want to make sure that we stay on top of that so that it doesn't become a problem throughout the rest of your life. Okay. So as a physical therapist, what are some things that we do to help treat pain? Okay. So I broke this down into peripheral, so out on the skin, on a limb, arm, leg, anything like that, and central. So that signal after it leaves the arm, leg, it gets to the spinal cord and goes up to the brain. Two different approaches to what we can do. So peripherally, hot or cold, generally if it feels better, unless there's some other reason, we'll recommend that you use it. Manual therapy and massage has some good physical and psychological benefits to that. Uh, it helps with healing at the local area to where the pain is, and it also helps release some endorphins and makes you feel a little bit better. Low frequency TENS, this is generally to get muscles firing, to make tissues a little bit more stimulated. Again, it can kind of help kick off a healing cascade and release some local pain inhibitors, and so that will make us feel better. And the same thing kind of works with aerobic exercise. So getting muscles, getting tissues moving also helps release endorphins, which has been shown to kind of cut pain levels a little bit. So that's kind of the approaches that we take. Now, centrally, we use a little bit different technique. So we use high frequency TENS here instead. And this is where we're trying to stimulate receptors that pick up, pressure and stuff like that. And we're trying to kind of flood the system to kind of drown out that pain stimulus or that pain sensation that you feel. And it's been shown to be pretty good. The problem with that is it only really works when you're using the TENS unit. And so generally what works best is if you use that high frequency TENS and then do some exercise, may allow you to get through. I talked about that fear avoidance, may help you get able to start doing some stuff without feeling that pain that you would normally feel. Again, manual therapy, massage, and aerobic exercise, these are good these are good treatments. They do release those endorphins and our natural opioids in our brain. Those all help modulate pain centrally so that even if we're getting, even if it's been sensitized a little bit, we can help start cutting down that sensitization. Okay, some additional things to think about and things that PTs will kind of help point you toward. Behavioral modification. You may be doing something that's exacerbating the pain, but you may not even know that you're doing it. So these are things that we really look at. We ask you a lot of questions about what you do, what could be causing your pain. And as you progress through therapy, we kind of reintroduce you to those things in a pain-free way. Being aware of different things that cause that pain to be worse is really important. Avoiding those aggravating activities. Like I said, education about what the pain is, where it's coming from, and mechanisms to treat it, mechanisms to avoid it. Those are all really important things in addressing pain. And like I said before, there is kind of a psychological component to pain, especially chronic pain. And so, if it gets to that point, we have some introductory assessments, and then if it's beyond what we can do, we'll typically refer you to somebody like a pain treatment or a specialist or a psychologist that deals with pain and stuff like that. Okay, that's really all I have as far as pain. It's a very complex topic. I tried to boil it down to stuff that was digestible in kind of a short time. Please feel free to send questions. It's a really exciting area right now because it's changing a lot. We're learning a lot more about it and ways to treat it. And so, this is the best we kind of know right now. I'm sure that will change. So ask a lot of questions. All right. Now we're going to transition into balance. This is also, I'll be talking somewhat about similar sensory receptors, but this is a little bit different. Okay. So our balance system is, how we keep upright, how we know where we are oriented in space, and how we navigate uneven, or how we kind of navigate any path or environment. And there's three main systems that we use. So our vision is probably our biggest one. And as we age, we become more and more dependent on our vision for our balance. And so this is why it may be more common for people that are a little bit older to have more balance problems. Okay. Our second big system is our vestibular system. And so this is a system that's located kind of right in our ears, and they help detect head movements and head orientation in space. And I'll go through that in a little bit. And then finally, our peripheral sensation and our proprioception. So this is those muscle spindles that I talked about, and it tells us kind of where our arms, legs, joints are in space, and then we use all this information and we integrate it together to detect kind of how our body is moving, how we're positioned, and then we can make kind of informed decisions about how we need to adjust our body or adapt so that we don't lose our balance. Okay. So vision. This is, like I said, probably one of the most important concept or components of balance. It allows us to detect objects as we're going. If we're walking and the grade of wherever we're walking, the trail or whatever changes, we can see that. We don't have to be surprised when we get there. We can kind of anticipate it and then make adjustments as we go. Okay. It helps orient ourselves to level. So if you ever have kind of fallen down or laid down, it helps us when we get back up. We can orient ourselves so that we're sitting upright or standing up straight. And then it helps us identify objects that we have to navigate around. So we don't trip or anything like that. Okay. The next big system is the vestibular system. And so here's kind of a schematic. Here's an ear, and then here's your auditory canal. Here's your eardrum. And then behind the eardrum, you have this big kind of system back here. This is both your hearing and your vestibular system. So this down here, this is called your cochlea. This is where sound waves are transmitted. This is where we detect sound. Okay. Up here, these are our vestibular organs. Okay, so you have three semicircular canals or semicircular ducts. You can see they're all oriented about 90 degrees to one another, and so that when we move our head, we can detect different movements. And then we have this big piece down here. This is kind of filled with fluid. And what happens is when we move our head, fluid flows through all these different canals, and we can detect that. And it sends those signals to our brain so we know which way our head is moving or which way our head is oriented in space. Okay. One thing to note, both your hearing and your vestibular sensation are transmitted to the brain via the same nerve, the vestibulocochlear nerve. Okay, and so sometimes when you have balance problems, you may also have hearing problems and vice versa. So this is why sometimes if you come in with a vestibular problem, we may not be able to detect some of the really small changes that happen either along this nerve or through this sensation. And so this is where you'd be kind of referred to a specialist for more specialized testing. Another interesting thing with the vestibular system, when we're moving our head, we detect that in the vestibular system, it helps us move our eyes so that our eyes trail along with our head, like if we're tracking an object or you're like watching a deer run across the field. This is one of the things that the vestibular system helps to contribute to. Okay, so I'm going to break down the vestibular system a little bit more. So I talked about the semicircular ducts, and you can see there's three. They're all oriented about 90 degrees to one another, so that when we turn our head in the three different directions, that we can detect those movements through these different canals. Okay, so kind of right at the end of each of these canals, there's a little sensory organ like this. It's called the cupula, And so what happens is when fluid flows through here, it pushes this back and forth, and then it moves these little hairs, and we can detect which direction those hairs are moving. And so you can see they're bending here. It sends that signal down the nerve into the vestibular cochlear nerve into the brain. Okay, depending on how much fluid, how fast it's moving, and how much it deflects these hairs or these sensory receptors, then we know which direction we're moving and in what proportion. So, we don't always move in just one direction, but we can detect in multiple directions. And so our brain can incorporate this into our balance and kind of figure out exactly where we're moving and how our head is moving. Okay. The other thing that is in the utricle, these are called otolith or otosensory organs. These organs have small crystals that are attached to the top. This is kind of like a jelly type fiber, or not fiber, jelly type compound. And so these little crystals sit on the top, and when we turn our head, the crystals move based on gravity, as you can kind of see here. And then the sensors that are in this kind of like jelly material bend and deflect based on how that material is moving based on gravity. And so this is what helps us detect if our head is tilted to the side. We can figure that out. We may not necessarily need to see as much to be able to detect that. Okay. All right. So I know there's a lot there, and this system can get very complex when something goes wrong. So if you have vertigo or BPPV, this typically addresses this system, and it can be a problem both out here in the semicircular canals, or it can be a central problem between that nerve and into the brain. All right, the last component of balance is our peripheral sensation, our proprioception. So I talked about muscle spindles before. They detect how much those muscles fibers are stretched, kind of how fast they're stretching. And this helps us just identify where our extremities are in space. And so if you're ever walking on uneven surfaces or you're walking in the dark, you do have the vestibular system, but we also have to sense with our feet, where our foot is, if we're stepping on something or if we have to adjust our balance so that we don't fall. Okay, and these are the sensors that do that. So a lot of our training in physical therapy, we work on kind of increasing the sensation here, improving your strength, and kind of recalibrating the system so that when you do step on something that's not what you expect or what's not, firm and flat, we can adapt and not lose our balance. Okay. So some of the common balance problems that we see, vestibular disorders, I kind of talked about this before. It may be something that we can treat. Sometimes those little crystals fall off that jelly compound, and when they get into the semicircular canals, they can make it seem like there's movement happening. This is called BPPV. We can typically treat that fairly easily and show you how to treat that. You're suffering from that. If it's more complex than that, or there's more than one thing going on, we typically refer to a specialist because they can do a little bit more specialized testing and treatment to really nail down what's going on. Outside of that, decreased proprioception and desensitization, not being able to detect, where our foot is in place. If you have peripheral neuropathy or decreased sensation in the leg or the foot, this can be a big problem with balance. Also, impaired vision. If we can't see as well, we need to rely on our proprioception and our vestibular system a little bit more. But still, vision is very important for balance and seeing where we're going. And then finally, decreased strength and reaction time, especially as we age. If we become less active and start losing strength, when we have to adjust, to catch ourselves with balance, sometimes that becomes a little bit more difficult. And so these are all things that we work on and we treat here in physical therapy. Okay, so now I'm going to go through a few exercises that you can work on both to kind of stimulate these systems and then also work on, your balance. One caveat to these is, if it's a standing exercise and you don't feel safe, then don't try it at home. You don't want to fall. That would be a good time to get a referral to physical therapy. We can work on that with you, at least make it safe for you to do some of these exercises at home. So, if you don't feel safe, don't do it. Don't fall. That's the number one rule. Okay. Um, so one of the things that we can work on, if you happen to lose your balance when you're turning your head or looking around, like grocery shopping, one thing that we can do is start in a sitting position in a nice, comfortable, stable chair, kind of leaning back. And what you can do is you can work on turning your head side to side and up and down. This is kind of all I'm doing here, looking back and forth. And you can look up and down. This is kind of calibrating and getting our vestibular system a little bit more ready. The last thing, if you're sitting, you can't really tell, but I have my eyes closed here, so I'm kind of taking my vision away. As long as you're sitting in a safe position, you can try this. I would not recommend doing it standing if you have any balance issues whatsoever. Okay? The next thing you can do, if you get pretty good at this, you can do head turns with no problem. You can actually transition to doing this standing. This is what I'm doing in this video here. One thing I would recommend, always have something to hold on to or to put your hands over so that, if you do start leaning one way, you can detect that and then catch your balance. Again, no falls. That's the rule. Okay, so a good thing to use here would be like your kitchen counter, grabbing onto your kitchen sink. This is a treatment table, but safety is always number one. Okay. So there's a way that we typically progress balance exercises, and this almost always starts with just balancing your normal stance. So standing with your feet roughly shoulder width apart, making sure your balance is really good there. And then we go to moving your feet together, and I'll show pictures of these. And then we go to tandem stance, so heel to toe. And then the most challenging one is single leg. Okay? It's always best to start with using both of your hands for balance support. Okay, so it may seem really simple, but progressing until you can do a couple of these for about 20 seconds, and then you can progress to the next level of difficulty. So, for example, here I would start with both hands until I work through this full progression, and I can handle that no problem. And then I would go to just using one hand for balance for support, and then I would go through this whole system again, or this whole sequence again. And then eventually you can work to your hands just kind of hovering over that counter, so it's there if you do need it, but still, again, you'd work through the same progression. And then the last way to make it more difficult is to go from kind of a firm, smooth surface to standing on something that's either soft or a little more unstable. So a good example for this would be a folded up blanket or a pillow. Just make sure it's not going to slip out from underneath your foot. And then when you're doing this, you kind of start back over at the beginning. So both hands for support, start with your normal standing stance, and then progress through this system again. Okay, so there's a lot you can work on, and it gets much more difficult when you go to a softer, more unstable surface. Okay, the last thing you can do, and we'll go over, is dynamic balance. So standing on one foot and using the other foot to tap something, or stepping over a rolled up towel, or standing on one foot and then reaching with the opposite foot. Okay, again, I just want to emphasize, don't try anything here that you feel is too challenging. If you feel it gets challenging and it's a problem, that'd be a good time to get a referral for PT, because we'll make sure that you can regain your balance in a safe manner. Okay, so here's some examples of balance. Here is, this is just doing marching. So standing on one leg, raising the other leg nice and high, getting good balance. See, you have my hand over the table, just in case I need to catch myself for balance. The next example here, I'm standing on a soft surface, and you can see I'm tapping my heel forward and my toe backward. This would be a more advanced exercise. And then you can also go kind of out to the side and across. This is more a lateral balance and stability. Okay, and then we'll transition here. This is stepping over a rolled up towel. Again, having a counter or something in front of you is very useful, should you need it to catch your balance. And then the last thing we have here is standing in one foot and then tapping your foot on the top of a cone, or you can really use any object here, like a step stool. The goal is to have really good control and not lose your balance and be able to do that whole tap without having to catch yourself. Okay, so that's everything for today. Please email any of your questions to pttalks@richlandhospital.com. Also, if you're participating in the Be Well Bucks program at the hospital, please send an email just to let me know that you participated. And just want to thank you again for your time. All right, have a great day.